Welcome to PodcastRx, a new monthly podcast from Diamond Pharmacy Services.
Each episode is a conversation with the men and women who make Diamond the nation's largest correctional pharmacy provider, Pennsylvania's largest independently owned long-term care pharmacy, and a trusted retail pharmacy and medical supply provider to many in Western Pennsylvania.
We chat with pharmacists, nurses, technicians, and other key personnel for a deeper look at the administrative, clinical, and logistical challenges of filling prescriptions and delivering healthcare, from our local counter to across the country.
And we also get the occasional glimpse into the professional journeys of our guests and why they chose the careers in pharmacy and healthcare.
Chris Cicuto, PharmD, has been with Diamond just 4.5 years, starting his career in the Drug Information Center before becoming a consultant pharmacist for correctional facilities in several states. His relatively fresh perspectives on correctional medicine and consulting made him an ideal guest for this show. In this episode, Chris gives us plenty of insight into building relationships at all levels of the corrections care team, the challenges of applying clinical precepts in a practical manner, and the pharmacist's place in delivering both cost-effective and quality-driven care. It's an easygoing conversation that covers plenty of ground, and we hope you enjoy it. I'm Adam Campbell, and you're listening to PodcastRx. Chris Cicuto, PharmD, joins us here on PodcastRx. Chris is a clinical consultant pharmacist for facilities in Alabama and Florida, and he's also a former member of the Drug Information Center here at Diamond. Chris, welcome to the show.
Well, thanks for having me, Adam.
Yeah. How are you doing today?
I'm doing well. It's a nice quiet time to sit down and have a little conversation with you from the hecticness of an everyday.
Hecticness of every day. Well, we're going to talk about the hecticness of every day. Is that even a word?
It seems like at the end of the day, it seems appropriate.
The hectic nature in the life of a consultant pharmacist. That's what we're going to talk about, among many other things. So I have to ask right away, Chris, I know you're relatively new to Diamond. You've been here, if I remember correctly, been here like 3 years?
4.5. My time goes.
Forgive me. You're relatively new as a consultant pharmacist for the corrections facilities. You started in the Drug Info Center before that. So take us back to coming to Diamond. What was that like? What was it like working in the Drug Info Center and then eventually working as a consultant?
Well, I came from a little bit of work in the hospital and in retail, but coming to Diamond and getting into correctional medicine was another twist on both of those. Just the medicines that get used and working within the restrictions of each correctional institution in order to deliver care is challenging because I learned early on that safety is the most important aspect for any of those facilities. So that may limit the times that are available to even administer medication. So something that would maybe be 4 times a day might only be 2 times a day in a correctional institution. So just differences like that, due to the restrictions on movement and things, was an introduction to me, and then it just kept going from there.
You mentioned safety. What other kinds of occupational challenges are there for a correctional pharmacist like yourself?
Well, logistics, getting the medication there, because we're in Pennsylvania, and as you had mentioned, I have facilities in Florida and in Alabama. So, meeting the needs of the facility and the patient to get it there in a timely manner. Some facilities don't have a prescriber on site all the time, so getting in touch with a prescriber can be even challenging. Nursing staff is oftentimes pulled in other directions, and sometimes there's high turnover. But by and large, my facilities have been relatively consistent, and as we'll probably get into a little bit more later, that it's just really honing in on developing those relationships so that you have those contacts and you know who to call and how to get in touch with them.
Sure. Before you got the consultant pharmacy role for the facilities in Alabama and Florida, you were with the Drug Information Center. Now, you talk about relationship building. I assume you dealt with those same care providers now in a different way. They're calling you to ask you questions. Was there kind of a planting of a seed to grow those relationships as in your role as a drug information center pharmacist that you've carried over into the consultant role, or how different was that being in the drug information center to what you do now, where you're kind of the boots on the ground?
Oh, I would say it's considerably different. I mean, it was a nice start and introduction to the practice environment. But just to go back a little bit about Diamond's Drug Information Center, I find it to be unique to the correctional pharmacy industry. I don't know of any other place that has 5 clinical pharmacists available Monday through Friday to answer clinical questions, address any regulatory concerns, or troubleshoot therapy with what is available. Or, I mean, as we'll get into it, maybe there's even a less costly comparative treatment out there that the provider wasn't aware of, because most providers aren't aware of costs right up front because they're delivering care. So the clinical environment was in the Drug Information Center is somewhat removed from the daily operations that is challenging as an account consultant pharmacist, because it's the practical application of the clinical. That's kind of where my role grew from the theory to the application. So just because it sounds good, can we do it?
Yeah.
And how are we going to do it?
Yeah. Those questions, I'm sure you're asking yourself then every day. Every day is a new, how are we going to do this? That's fair to say?
I mean, it can be.
Yeah.
You never know. I mean, my day could be quiet and my day could be exceptionally fragmented and busy from just an email or a phone call, and then it's just another email and a phone call and another one. And then that project that I was working on in the beginning of the morning is now hopefully for the next morning.
You mentioned your day can be hectic, your day can be quiet. What kind of issues are typical for you? Or is there no such thing as a typical issue for a consultant pharmacist?
No, I mean, I think it can be typical, but I mean, an average day could be, why didn't this come in my shipment? This was marked manufacturer back order. What can I do? To troubleshooting a REMS program and getting some blood work, some stat blood work done, so that, like, for example, the clozapine REMS requirements can be met, so that medicine can go out. Making sure their day for each facility goes smoothly. So it could be a stock med, it could be a doctor with a question, calling a backup pharmacy to see what they have available, so that the facility can get an emergency prescription filled, to nothing. The sweet sound of silence. It doesn't happen very often, but
yeah, for a few minutes maybe, and
then but there's always something to work on. But just that one moment of quietness. Usually it's at the end of the day, but I mean, there's reports to be done. I like to get probably a little too far down in the weeds sometimes, but like,
how so?
Well, I guess it's a little micromanagement, like, or babying people. Like, I just want to make sure everything goes as smoothly as possible. And sometimes there's just like little holes or miscommunications, or someone didn't understand what refill too soon means, or maybe it's not a refill too soon. Just little nuances that then cause little hiccups along the way, and then that can get larger and larger. So if you can grind them down and keep them small.
This all ties into something I wanted to ask you about. Now, here at Diamond, our consultant pharmacists are seen as account managers. It starts with sales, and of course the sales team is still involved through, checking on the customer and things like that, but really comes down to our pharmacists, kind of the shining stars. And so you're an account manager for these facilities in Alabama, Florida. And you've got to go out and you got to build relationships at all levels of the care team. So that's everyone from the med groups we work with, the nurses in the jails or the prisons, the sheriffs, the doctors. Correct me if I'm wrong. So what has that been like for you to build relationships with all these different stakeholders?
I mean, for me, it's a lot of fun, and I get a lot of enjoyment out of that part of the job. You get to know, your one bedroom manager. She's out with the grandkids for the weekend, or the other one just bought a house. So you develop those relationships even from a distance, which helps because there was another consultant here that told me it's always easier to make a mistake with a friend than with an enemy.
Good advice.
Mistakes are inevitable, but we all make them. So yeah, it is. So I try to have those relationships so that when the mistakes happen, that we can work through them. So it's fun to have like my people that I can call. I know who to call at this place, or I know who to call at that place. And if I know a little bit of even what's going on in their life, then it just keeps it all nice and fluid.
Right. And you mentioned too, mistakes happen, but of course you're in the business of healthcare for the population. So, these are mistakes that involve lives. So of course, having those good relationships up front with the providers and all that, just ensuring consistent care too, goes a long way. Yeah.
There's a lot of steps in the process before that mistake gets to directly affect the patient.
Sure.
So by having those relationships developed, it just makes that easier. A lot of times more often than not, it doesn't reach the patient because it's been caught in the process along the way. And, and then that's my job. Well, what can we do to get it right?
Yeah. When you're working with at any given facility, is there do you answer more to like the nurses in one facility and more the med groups in the other, and certainly, steer me in the right direction here if I'm asking the question wrong, but is it pretty different facility to facility as far as who you're working with to make those decisions or help make the decisions regarding the care? And
no, it's the same for me. I spend a lot of time with the people on the ground, the operational folks in each facility. But at the same time, I have relationships with the regional medical directors or the state director for that particular discipline, medicine or psychiatry, and then all the way up through, if I'm working with a private medical group, that corporate entity. So quarterly you're looking at pharmacy and therapeutic meetings, and so you have those interactions and that accountability too at the end of the day to them all the time, but also to the people on the ground.
Yeah. Now, something when we were preparing the outline for this episode, you mentioned to me the importance of troubleshooting. Now, of course, you're an account manager, so manager means you have to troubleshoot a lot of different issues. One that you brought up to me when we were talking was there were some med carts that needed to go up a floor, and it's how are they going to do that? And they turn to you for help in that. If I've got the details on that right, I did note it here. If there's anything about that, certainly clarify. But what's the troubleshooting experience like? I know you said that you have a pretty clear communication chain with all these different folks, but what kind of troubleshooting do you have to do?
Well, retail probably best prepared me for that.
Yeah.
Aspect of account management, and that's in retail. The buck stopped with the white coat, so that went from working through problems on insurances and things that typically you would think to the register doesn't work, or the toner needs replaced, or the printer's broken, or the label machine's broken. So at the end, and at that point in time, it's not anyone else's job to get it done at the end of the day, except the white coat, because that's who runs. So it's similar like you mentioned about getting med carts up a floor, like getting medicine up a floor, up steps. I mean, I made a suggestion. I'm not to this day, like the problem is still in progress. I don't even know if the suggestion was helpful, but like sometimes you have to think outside the box and troubleshoot something as how do I get if I can't get the cart up the stairs, how do I get the meds up the stairs? To what am I going to do when my shipment doesn't come? And if you can see you can get out in front of some situations, like if you can identify, well, this isn't getting addressed, particularly at the site level, like when is it time to escalate the concerns up to the next level, so that before it becomes a real problem on the ground, you've reached out for an additional help, but at the same time, not too early, not too late. It's kind of just right. It's not always just right, but if you can get it that way you don't offend anyone or ruffle anyone's feathers or ego, and at the same time, you can get the problem solved before it's a critical problem.
Yeah. And of course, you mentioned those relationships. It all comes back to that. I would think that you build those strong relationships, the easier it is to troubleshoot things, or at least, get that collaboration. It doesn't all, yes, the buck stops with the white coat, so to speak, but you have plenty of help in achieving whatever you set out to do. Oh yeah,
no, I certainly can't do it, not nearly alone, and I like to think I'm not that integral where the process would fail without me. I do like to think I keep it more interesting. I think laughter is the best medicine. If we can get off the phone and we're laughing, then that's a fantastic phone call. And I want, when my number comes up on someone's phone, they're not like, oh, voicemail.
Yeah.
But they're like, hi. They're like, how you doing? Well, so that's helpful.
Thanks so much for listening to PodcastRx, a production of Diamond Pharmacy Services. While we're taking a break here, we'd love it if you took a moment to follow Diamond on one or more of our social media platforms. On the corporate end, you can follow us on Twitter @DiamondPharm, connect with us on LinkedIn via our Diamond Pharmacy Services company page, and also subscribe to our Diamond Pharmacy Services YouTube channel. Our long-term care division has a Facebook page, and you can find that at facebook.com/DiamondPharmacyLTC. They also have a LinkedIn showcase page. Just search for Diamond Pharmacy Services Long-Term Care Division. If you're a listener in our hometown of Indiana, Pennsylvania, our retail drugstores and medical supply stores also have a social media presence. Find them on Facebook, page name Diamond Drug Stores and Medical Supply, on Instagram @diamonddrug.medsupply, or you can subscribe to the Diamond Drugs YouTube channel. We really appreciate your support of the podcast and would appreciate your likes and follows on these social media channels. Now back to the show.
So you're accountable to the groups, to the med groups, to the actual health staff at the facilities. What's that been like, moving over from drug info to now that you're the top dog in as far as the pharmacy is concerned? What's that been like for just that accountability and managing that end?
No, it's the best when it goes well, and it's the worst when it goes bad. But, but the process is good because most importantly, I'm accountable to Diamond Pharmacy. So by being accountable there, then I keep that's an integral part of the process. So at the end of the day, I'm accountable to Diamond Pharmacy too. And, and that is what, and that's what keeps going to the next day, because it is bigger than myself.
Just looking at you again as an account manager now, you're talking, we talked relationships, we talked the importance of building that with the staff. Now here's kind of where the rubber meets the road, so to speak. There's no surprise to anyone that healthcare in general is expensive, but of course, prison, correctional facility healthcare is very expensive as well. I was looking at some Pew Research data from 2017, the most recent study, that per inmate spending on prison health care, it varies greatly between states. In California, they spend almost $20,000 per inmate, while Louisiana spends a little over $2,000. There's a lot of variables in between. And it's just, again, every state does it differently, as you can attest to having facilities in 2 different states. And then there's med groups and all those things in between. And states spent $8.1 billion in 2015. That's a fifth of overall expenditures. That's on healthcare alone. And within that, getting into pharmacy, prescription drug costs are the primary cost drivers of the overall prison healthcare in many states, not all. So obviously the pharmacy and the pharmacist, very important. So now that you're an account manager, you're a consultant pharmacist, how do you play a direct role in managing cost-effective care, which is at the forefront of any state's budgetary concerns?
Yeah, no, I mean, that's a challenge every day, because, I mean, the market changes often. The market can change oftentimes daily for the cost of medication. So it is my job to identify those times where maybe a preferred agent, the cost went up, and there's a less costly alternative agent that either is not on the facility's formulary or preferred drug list, or isn't commonly used, or wasn't there. Maybe before, at one point it was expensive, so it kind of just fell out of the prescribing pattern. To identify that and then recommend some alternate therapy.
Is there any types of drugs or classes of drugs that you find this happening a lot with, or more often?
I mean, typically generics are viewed as less costly than brands, which is true, but the generic manufacturing market has gotten concentrated. So if you get a single source generic company, I mean, you've read the stories of Pharma Bro and people out there that a medication that was $17 a month is now $700 a month. So you have those market factors going on that are well beyond any scope of influence that we have, but at the same time, communicating that along down through the chains, because the providers that are prescribing don't necessarily know what medications cost. They have a lot of other things they have to worry about, and they count on a good account pharmacist to make those to catch those things, and then to make those alternate treatment recommendations.
So getting this info to the care team, like you just mentioned, catching those changes in the market, changes in drug prices, things like that. How easy is it to see those, is it easy to have your recommendations implemented? I mean, I know you just make the recommendation ultimately.
Oh, yes. Ultimately, it's prescriber's preference, prescriber's privilege to do what they see best fit for the care of that patient. No, I mean, by and large, most prescribers are welcome the opportunity for the discussion, and then more often than not, from there, many of them take the alternate recommendation, or they're willing to try it first and see if it works. I mean, but Forrest Gump, it's like a box of chocolates. I mean, you never know what you're going to get.
Question that kind of goes in with what we were just mentioning. So you make those recommendations for cost-effective care, but what ways can the pharmacist, especially in the correctional facilities, ensure not just cost-effectiveness, but quality?
I mean, it helps to have not just the communication. In my opinion, it helps to have the communication with the people on the ground too, because if having the therapy changed and then understanding and why oftentimes doesn't get translated down. And again, we started in the beginning about relationships. I mean, communication is the cornerstone of any good relationship. So, and the same applies in the healthcare system. But if people don't talk, then they don't know. Then a cost-effective alternative could turn into be more costly because someone didn't understand something and something got done this way instead of that way, and then the patient goes out for an acute episode or for higher level of care than what was originally intended. So so not only is it getting it the alternate treatment recommended, but then having that communication on down through, so that you don't have much say in that direct patient care, but again, the communication behind the scenes can at least do the footwork for a successful situation.
I know with in jails and prisons, you see a lot of medications that are just medication for one thing's very expensive, like Hep C meds or HIV meds, things like that. With your facilities that you manage, do you see a lot of those bigger cost drugs?
A lot of those costs are just actually considered standard and accepted. Like HIV is HIV. Like, and if it takes up 30 or 40% of the pie every month, and it's like that's just accepted, and you have to move on. I mean, it and that kind of, again, it depends a little bit on the drug markets, but as soon as a HIV regimen comes out and it's all generic, you can bet there's a combination tablet brand or the next newest one out there on the market that many people they're coming in on because that was what was covered by Medicare or Medicaid or their private insurance. So sometimes you have the opportunity where you can recommend like breaking up a single tablet regimen into lesser tablets, or if someone's on an injectable antipsychotic where they could be transitioned depending on their length of stay to a less costly oral alternative because there's direct observed therapy. There's someone that hand them the pill to take as opposed to remembering to take a pill. So then that tends to be less costly than getting a once a month, injection, if that's possible, depending on the practice environment. Or again, that cost is just passed on because breaking up the stabilize that any incongruency or any discontinuity to their care further jeopardizes the cost of managing that inmate or patient, because they're destabilized, and then then it's time to establish that structure and that stabilization again. So those are questions that medical groups face, every day, every month, every year when they look at their budgets and their books.
We're going to take a little break now to tell you a little more about the Diamond Drug Information Center. On a personal level, we all appreciate when our pharmacist gives us a thorough consultation for a new or complex medication. They dispense not only the drug, but important information about dosing and possible interactions. This kind of medication counseling is easy to understand on a personal level, but what about on an institutional level? Where do healthcare providers, especially those delivering care to large populations with diverse needs, go when they need medication counseling? Enter the Diamond Drug Information Center. The pharmacists of the Drug Info Center dispense in-depth clinical consultation for all of Diamond's customers, from correctional facilities to nursing homes. This team of PharmDs specializes in pharmacotherapy and disease state management. And if you have questions about dosing, drug-drug interactions, non-formulary medication requests, therapeutic alternatives, or you just need general clinical advice, they're a call away. They also take proactive steps to educate healthcare professionals. They issue regular clinical updates, and they develop webinars and presentations about specific drug topics. You can reach the Diamond Drug Information Center at 800-882-6337, extension 1834, or email them druginfo@diamondpharmacy.com. And now back to PodcastRx. What's your process because the prescription drug market, pharmacy in general, there is obviously a lot of information. And what is your method for staying on top of that as an account manager, tracking all those changes in drug prices, therapies, all of that?
Oh, I get dumber clinically every day, and my clinical folder and my Outlook is full, and I get to it when I can, but it's helpful to have Diamond's Drug Information Center. They pick up on those things. They monitor reports, even retrospective reports. Because it's impossible for one person to manage it all. So so Drug Information Center keeps me and other consultants, we run stuff by each other. Hey, there's this or there's that. And if that situation or scenario applies to you, you can take it and run with it and look good. And if not, then maybe you have some next time for someone else. But so it's working with my colleagues here, and I mean, yeah, I don't do it by myself by any means.
Certainly. You mentioned in another conversation we had that, you've never seen so many pharmacists under one roof like you do here at Diamond. So,
yeah, it's intense. It was a stark difference from, in the hospital you have a handful of people, but retail you might be the only one. Yeah. And here there's up to 40 at any given time, like during the day, that could be your...
Yeah. How rich is the collaboration between pharmacists here as far as it comes to consulting for correctional facilities? There's quite a bit of you just in that world. You meant there's a lot of pharmacists here in general, but just among consultants, we have quite a few.
Yeah, I just think there's quite a few. And then, just the staff pharmacists on the ground that are every day in and day out verifying orders and stuff. I feel like there's a pretty open level of communication. They bring any issues that they've identified up for either higher clinical review through the Drug Information Center or back through the account consultant and say, hey, I saw this. I just wanted to let you know, make you aware, So no, Diamonds, I think we're very open to that.
Going back to the facilities a second, a question I wanted to ask you, like the care goals between the facilities that you oversee. How different are the care goals of those facilities? How do you adapt as a pharmacist in those situations?
No, I think by and large it's similar across the board. There's a provider that's trying to offer the best, most appropriate, hopefully cost-effective therapy. And I say cost-effective therapy because there's only so much of the pie. So like if you don't have to spend 2% here and you can only spend one. If you can offer that same level of care and spend 1%, then they give you another 1% that you can spend somewhere else. And just that little bit can go a long way. Plus with fluctuating drug costs and stuff. But across the board, I think it's a very challenging practice environment for a physician or for an extender, a nurse practitioner, physician assistant, and they're all out there trying to do the best they can with the limited resources that they're often left with. So,
pharmacists now are seen more than just the medication dispenser. They're seen more now as integral to the overall care team. And you've been in pharmacy, you've been a practicing pharmacist for how long now?
I graduated in 2005. So
2005, okay.
A few years.
Yeah. And it seems like that the perception of that role has just gotten larger. So from when you started in pharmacy, not too terribly long ago, but what kind of changes have you seen from then to now in terms of practice? Not just in the different jobs you've done, but in general as the bird's eye view.
Oh, that's a big question. I almost don't know how to answer it. I feel like it's gotten like the drug manufacturers essentially have become more concentrated. You have less of them. You have the larger, pharmaceutical companies. Like for example, you have 2 companies that make your basic insulin. So whereas before it seemed like there were more. So there's a concentration of manufacturers in the market. I think that anyone that's involved in the care can identify, and it's been documented that there's been quite a few manufacturer backorder, like medication shortages. That's tough to keep up with. What do you do when a hurricane hits Puerto Rico and a large percentage of sterile products are made in Puerto Rico, and suddenly normal saline in liter bags is hard to come by, or another manufacturer has a manufacturing problem in part of their process, and then that particular product is in short supply. EpiPens, for example, and things that epinephrine you wouldn't think would or should be in short supply, but all of a sudden, the FDA is going out and extending expiration dates and trying to make what little is left in the market last longer. So I definitely have seen an increase in that. HIV drugs that were brand are now generic. Ones that I learned about in school we don't even really use anymore. So it's constantly changing and innovating. The challenge is to get some of that innovation into, the smaller budgets of correctional pharmacy. It's fun because then that makes it fun for the prescribers too, because people want to try new stuff. Keep their job interesting. So when you can do stuff like that, that's fun.
Yeah. How often do you find yourself sharing that new information with providers, educating the providers?
Again, I have to throw it back to the Drug Information Center. They do a good job of getting that information out to us in our hands, or out into the quarterly clinical updates that get sent out into all of our groups. So, I rely heavily on them for that. But yeah, that's the fun stuff.
Yeah. Now, you've not been doing this consulting for very long, and you talk about innovation and things, but where do you see the role of the clinical consultant pharmacist going? What kind of change? Do you see any changes in the overall role you have? You see any expansion in any given area? Any ways that the inmate populations or the issues at large in the community will alter what you do, even if it's a small way?
For me, no. For me, it's like I'm what you get. Everyone has their own different style and flavor to do things. Some people are more hands off and they let the process go, and other people, I like to just get probably a little too much into it. Sometimes I have to dial back a little bit,
how so?
Because you just can't micromanage. You can't read every report every day.
Mm-hmm.
So it's nice to get in there and know what the report is and what it means and what it says, and be able to glean some of the important stuff off of it, and then and just monitor how things are going. But it seems like there's always one other report to monitor, and it's just having the time of the day to process and do something with them all. Sometimes challenging, but
sure. Well, you mentioned time, and we've certainly taken quite a bit of yours. So, Chris, thank you for being on PodcastRx.
Right on, Adam. Thanks for having me.
All right.
Privilege and a pleasure.
Thank you, Chris. This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Find new episodes of the show on SoundCloud, Stitcher, and Google Play. And please subscribe, share, and leave us a review. Music by Maximiliano Silvera, Sound Express by Getty Images.